Well, good morning, everybody. It's a real pleasure to welcome you to this final panel of the 5th Mental Wealth Festival. I'm Sheila Hollins, and I'm the patron of the festival and one of the founders. I know that people are joining as I speak, but we only have an hour, and so I think it's important that we really do get started. I'll just explain a little of the background. The festival started as a partnership between CityLit and the charity that I founded called Beyond Words, which now has its office base within the Institute's buildings. To begin with, the festival was just a couple of days of workshops and activities at CityLit. If you don't know CityLit, it's in the centre of London near Covent Garden. Our idea was to focus on mental wealth, the things we can all do to build our resilience and look after our mental health. And since then, it's grown to include sessions in the House of Lords, usually, in the National Gallery, the British Museum, and other wonderful venues. But this year, of course, we're online and probably attracting a bigger, we think maybe double the audience, but a slightly different audience than in previous years. And this morning, probably whilst we're online, the festival will be broadcasting a message from the Mayor of London, which is wonderful. So today's panel discussion is about death and dying during the pandemic, and I have the pleasure of hosting a discussion with Dr. Katherine Mannix and Professor Irene Tuffrey-Wijne. And also Charmaine and Alison, thank you so much. They are going to be doing sign language interpretation as we go along. It's a tricky topic to talk about, particularly perhaps because we, the panel, can't see you, the audience, and we can't interact directly with you. We know that some of you will have experienced life-threatening illness, death, or other losses during the last few months. And our conversation today is about the experience of dying for any reason during this time. Now, quite an important piece of information for you. If you'd like to ask a question or make a comment, and we'd be pleased to hear from you, please can you do this through the Q&A function on your screen, not the chat box. And I will try to keep an eye on what you raise, and if possible, try to bring your question or concern to the attention of the panelists. Okay, so to introduce our speakers. Katherine Mannix, Dr. Katherine Mannix, is currently working as a palliative care consultant in Northumbria, I think, having come out of retirement during the pandemic. She's written the best book ever about death and dying. It's called With the End in Mind. Now, I understand this is a rare first edition copy and it's now in paperback. Perhaps, Katherine, you'll waive the paperback version. It's called With the End in Mind, Death and Dying in an Age of Denial. Katherine, could you start by explaining what you've been doing during the last few months?
Good morning, and thank you for inviting me. Yes, so I retired early from a career in palliative care, where I was working in a hospital palliative care team, to try to do something to help the public misunderstanding and fear about dying, which is how the book and a variety of other things came about. But of course, lots of doctors who had recently retired were invited back into the workforce as the COVID numbers started to rise. And I was one of those. And so I've been working with our local big hospital trust in Newcastle City, not at the bedsides of dying people, which has actually been really hard, but as somebody who is supporting the people who are doing the bedside work, both with support and debriefing, and working with the trust's clinical psychology and chaplaincy teams, who are offering quite systematic support to staff, and lots of trusts around the country are doing this. And also to devise and to produce information about communication skills training. Lots of people are having to have really tender conversations, breaking unwelcome news, often over the telephone. And because the numbers are so large, it's not always the staff who have the most experience and confidence in having those conversations who are free to make the calls, and obviously keeping families up to date frequently through the day and not having them waiting for the most senior person to make the call is really important. So I have been helping to train staff from very experienced consultants have turned up for training, which is, I think, remarkable and humbling, and role modelling of them to very junior nurses, doctors, physios. And it's just been lovely to be able to touch base with them all and encourage them in what is really, really important work.
Thank you very much. We'll come back to some of that in a minute. But I want to introduce Irene. Irene is Professor of Palliative Care and Intellectual Disability, and I'm very proud of the fact that I supervised her PhD, which was about death and dying for people with learning disability. Irene published a very readable and moving book called Living with Learning Disability, Dying with Cancer. When I reminded her of this wonderful book, she said it seems such a long time ago now. You might want to say something about it, Irene, but I think Irene and I both believe that if we can get it right for people with learning disabilities, then we can probably get it right for everybody else. And so, you know, we mustn't forget people with learning disabilities during the pandemic, and it has been quite difficult. The number of people who died who have learning disabilities during the pandemic the excess deaths have been higher even than the excess deaths for the over 65 age group. So Irene, can I ask you, what have you been doing during the pandemic?
Thank you, Sheila. Yeah, so as you know, I'm a nurse by background. I used to work with people with learning disabilities and live with people with learning disabilities for many years. I've worked in a hospice as a nurse for many years, but for the past 2 decades, I've been very desk-bound, I suppose, doing academic work, doing research into end-of-life care for people with a learning disability. And that book that you've just showed was actually one of my first studies. I mean, what I've been trying to do as much as possible is to get the perspectives and the experiences of people with a learning disability themselves. And I think nobody really had ever done that before. So I've been thinking about death and dying and learning disability for decades, as you know. It's always been a topic that's been very difficult to get out into the open because people don't like to talk about death, and many people also don't like to talk about learning disability. So it's been really interesting during the pandemic that actually this issue of death and dying has become so much more prominent and talked about. But of course, if you have a learning disability, you know, it's doubly difficult. You're already excluded from, often from knowing about it, and being more isolated during this pandemic is even more difficult. So I've been, I suppose, trying to sort of reach out to all the staff and families and people with learning disabilities who are trying to grapple with these really difficult issues of death, dying and isolation. Through working with you, Sheila, on you know, Books Beyond Words has, you know, we've developed some, I think, wonderful picture and guidance resources to help people, families to cope with this. So it's reaching out in a different way, webinars and sort of easier writing that I've been doing.
Can you just explain about Books Beyond Words, because I mean you've helped to co-author some of the books and the resources, and during the pandemic, you're right, we've created some pictorial resources. I don't have any of you. Great, you've got something there.
Yeah, so here we are. So that's one of them.
Yeah, Am I Going to Die? Yeah,
is one of them.
And there's When Dad Died and When Somebody Dies, and the idea of them is basically that they're just in pictures, so there are no words to get in the way. So Kathryn, you were talking about telephone conversations and the importance of those telephone conversations, but trying to make those kinds of things available at very short notice. That's a large part of what you've been doing. What you've also done is to run what I would say is probably the best webinar that I've ever attended, which included pre-recorded stories about experiences of death and dying from people with learning disabilities. And you had more than 1,000 attendees. So I hope you have put details of where people can find the recording of the webinar which can be sent out to people afterwards, because it really is worth listening to, and it has a slightly different focus to today's conversation. But of course, Kathryn, you were also a participant in that webinar. Do you want to add anything else there, Irene?
Yeah, I mean, I think it's interesting, isn't it? I mean, there are different and new opportunities now doing this thing online, is in really being able to include people who don't usually stand up in front of a room of 100 people and speak, you know, just simply by talking to them on Zoom and recording it. So that was a lovely thing, to be able to include the voices of some people with learning disabilities. And I think with regards to books beyond words, I mean, there are a lot of more and more sort of easy read resources, if you like, to help people with a learning disability or communication difficulties, or people who don't have English, sort of understand issues, but they're usually focused on imparting practical information, you know, what is radiotherapy or what is cancer, for example. Whereas books beyond words is storytelling. It's helping people in pictures to really get to grips with not just what's happening, but the emotions behind it and how it makes us feel, and you know, starting those conversations. And I think I'm more and more convinced that that is actually what people need, is to really connect with the emotions and the experiences of things, rather than the facts of what's actually going to happen to you.
So in a way, you as a now an academic, and Kathryn as a clinician, have both been trying to help people to have those tender conversations, to sort of debunk the taboo, if you like, to enable that a bit more. I mean, Kathryn, I'd love to hear your sort of perspective about, you know, what how, you know, your perspectives actually are quite similar despite your different backgrounds and experiences.
Well, it's interesting that we both talk about storytelling so much, because when we think about what happens towards the end of somebody's life, what we know when people realize that the end of their life is coming is that they go back over the story of their life and they work out what it's been for and whether they've achieved the sorts of things that they had hoped. And very often for people dying in older age, they realize that they made a transition somewhere in midlife from thinking that what they hoped for was stuff to it being about relationships. And actually what we see people of all ages thinking about at the very end of life is about the importance of loving and being loved, and the story of how they came to be in the relationships that they are in with the people who are important to them. And over this webinar, I'll probably use the word family, but I very much mean that in the notion of one's village, the people who belong to us because we've chosen each other and because we love each other, rather than necessarily that we are related to each other. Mm. And when people are companions to a dying person, whether they've been able to be alongside them as is usual, or not been allowed to be alongside them, which has been one of the great heartbreaks of the COVID situation, they too are assembling the story of what's happening to this person in their final days, and what their last days and hours have been like, and what has happened as they've reached the end of their life. And those are the stories that we tell ourselves to comfort each other in bereavement. We talk about, you know, how grandma hung on till she heard that the baby in Australia had been born, or that Jenny died safely before the difficult news about a different family problem had arisen. And we talk about when they had their last cup of tea and what the last words they said to somebody were, and how we didn't really expect they were going to be their last words, but after that it seemed they were just too weary to talk, and then they became unconscious. So we tell the story and people keep chipping in and adding to the story, and that helps us and consoles us. And we do it with all big family events. Anybody who knows someone who's given birth to a baby recently will know that they tell that story over and over and over again, from, you know, the first tummy ache, the first contraction, the water's going, all the way through, blow by blow. And each time they tell it, it gets a bit more detailed, it gets a bit more elaborate. It's how we make sense of our lives. Stories are so important.
And the stories that people have been telling, they've perhaps now had to tell and share those stories with people that they didn't know. Or they've been storytelling or trying to keep in contact through the use of tablets or social media or telephone with family at home where visiting hasn't been permitted. How has that changed people's experience, Kathryn?
It's been really interesting listening to staff talking about this. That they are, because they are at the bedside and then they're making the telephone call or the video call, which again is such a difference. A year ago, hospital staff would never have thought of making a video call to a family. It was all telephone calls. And if they're working in a hot area, then they may, you know, COVID area, they may be making the phone calls, still wearing their masks for protection of the staff around them. But if they can come out, they can make a video call and the person can see their face. Whereas if they come into the hospital, it will definitely be a masked encounter. So one of the things we've been talking about is the importance of those little details that help people to know from both sides. The person who's in their care wants to know how their family are. And when we say they're fine, they say, no, but how are they really? Because they want detail. And the other way around, the family want to say the things that are in their heart that they would say if they were at the bedside. And as they realise that the opportunity to be at the bedside might not come, there may be one person allowed to visit, but they're not going to be the chosen person. What happens is staff are hearing these really intimate messages from families and from the sick person, and they're charged with exchanging those messages. And they found that incredibly powerful, very, very sorrowful. The biggest stress to all of the staff that I talked to wasn't how busy they were or how hot they were or the fact that they got ulcers from behind their masks, which they all had, but that they were witnessing the sorrow of people who were separated from each other. So they've taken that task as a sacred task, really, to be really, really faithful in giving the messages, returning the messages, replying to the messages, keeping families updated. And if there are people listening to us who haven't been able to be with a beloved person, I think it might be helpful to know that actually staff have done their most tender best to give the love that they know is required at a bedside. It's not just about care, it's actually about love, and that is really important.
Thank you. Thank you. Of course, some people have been allowed to visit, and that's changed during the time. But there was a lot of debate at the beginning about whether people in certain circumstances might be able to have visitors. And the idea was that if you had a learning disability, or you were an autistic person, or maybe you had dementia, that actually it would be extraordinarily cruel not to have somebody familiar at your bedside. Irene, did any of the stories that you heard from people with learning disabilities you consulted with, have they had, what kind of experiences have they had?
You know, I'm really quite struck with what you said, Kathryn, about you know, sort of the need to make sense of the story of your life when you come to the end of it. And I think that's not just the person who is dying, it's also the people around them. I'm just, you know, sort of thinking back of last year when two of my very good friends, both of whom had learning disabilities, died within days of each other, Michelle and Carol. And there was a lot of, you know, we all sort of gathered together, thought about their lives, talked about them, and it almost is, it's like you make sense not just of their life, but also of your own. You know, I remember when my mother died, you know, how much my sisters and I sat around telling the stories of our lives. And actually, since then, it's almost as if our relationship has been transformed because we understand our own story better through that. So these are really important times. And I think when you ask about the experiences of people with a learning disability, one thing I think that has been so striking in what you're saying, Kathryn, is the difficulty during COVID to do that, to come together. And if you can't make sense of you know, of the lives of the people you love at the end of their lives, then the ripples of that, the echoes of that go on for years and years. I mean, you really at some point need to do that. And I think the best way to do it is to be together and to communicate. And of course, people with a learning disability, or now historically and even now, have so often been excluded from those opportunities. You know, not being included in knowing about dying, or that our mum is dying, not being allowed to go to funerals. So maybe in a way we're also experiencing a bit of how difficult that kind of exclusion is. And so when you're asking about the people I've spoken to, Sheila, of course the people I've spoken to with learning disabilities are the people who are able to manage Zoom and those kind of ways. And actually, in a way, for some people, this has opened up possibilities because we are reaching out to each other more. And I hear people say, you know, my family, we're now talking more on Zoom than they ever have done. So that's true for some people, and it may be true for, you know, for some of us. Certainly it's true for me and my sister. We talk every week now. We never used to do that. And we're going to carry on doing it beyond, hopefully beyond COVID. But I think it's been particularly difficult for people who don't have that ability to independently manage those social media type things, and who are dependent on, you know, on one or two people that can understand the way they communicate. You know, there might be only very few people who can do that. You know, and yeah, not seeing your mum being excluded is just so, it's heartbreaking.
Mm. I mean, what's been happening in hospitals and the work that you've been doing and the help you've been giving those staff, I mean, I just feel for both of you that actually helping people to talk is just such a crucial thing, you know, because death is one of those things that we don't talk about so much. And so trying to learn how to start the conversation, to have the conversation, is really, really important, isn't it? I suspect that the conversations you've been having are going to mean that those staff will be more confident around people who are dying in the future. I mean, this festival is about mental wealth, and it's about people building their resilience and so on. And some people talk about how staff, hospital staff, have become more burnt out. But personally, I would have thought that being more comfortable with those kinds of conversations would actually be part of building people's kind of confidence and resilience, rather than contributing to their burnout.
I suspect it's a little bit of both, isn't it?
Yeah.
That when we're first learning, every time we try to have a conversation, or whatever the skill is that we're learning, we're using all of our energy and our attention, and it's really difficult. And it's just, if you compare it to learning to ride a bike without stabilizers, you can't enjoy riding the bike because you're so busy trying not to fall off and to steer and to keep the pedals moving and all of the rest of it. The idea that you could cycle for pleasure in the future is really far from your mind. So those staff who are in that kind of learning phase, they are doing their very best. They're bringing their tenderest self. And one of the things that we were talking about in the training was, this bad news is not your fault.
Mm.
And so please don't carry the extra burden of guilt because you have to have this conversation. You're having this conversation on behalf of all of us. We all are very, very sad that this is the news that has to be given to this family. So what your task is to enable them to understand how things are on behalf of all of us. And of course, sadly, they've had the opportunity to have those conversations repeatedly in a short space of time. And we know that that kind of practice is the sort of practice that builds a skill up. So now the numbers are rising again. And I think staff are anxious about how busy it's going to be, about those awful PPE burns that they get on their faces from the masks having to be on so tight, and how hot you feel inside it, or they're not looking forward to the physical experience. But I think they will be no longer dreading those conversations. The sadness that they feel that it's happening will still be there. But I think they'll have, you're quite right, a sense of this is ours to do, and I'm one of the people who can do this. I can help this family to understand this really unwelcome news in a way that helps them to make sense of it, and then I can take messages back and forth and be an anchor for them at a really difficult time.
I mean, one of the, can I just remind the audience, and thank you for the questions that are coming in. If you could put your questions into the Q&A box rather than the chat box, that will be easier for me to follow. So thank you for that. One of the questions is really about the support that might be available for people who are dying at home, people dying in social care settings, in homes. More people do seem to have died at home during the pandemic, I think. And actually, I think surveys about where people would like to die usually suggest that more people would like to die at home than in hospital. The question, I suppose, is what those experiences have been like, you know, and are people talking more about death and dying now? So those are some of the points been raised. Do go ahead, either one of you, to respond.
Shall I start? I mean, I think, as you know, I know most about people with learning disabilities, and for many years I've heard that, you know, people living in supported living, in care, in staffed settings, with care homes, for example, or, you know, supported living, there's a very strong feeling amongst many carers that they want to keep the person at home because that's where they feel most familiar with everything, etc. But of course, part of wanting to be at home is because you're comfortable there and at ease. And if the people around you are not comfortable and they're panicking because they are frightened and worried, then that is not going to be any good. So I think, you know, a big part of our job as palliative care professionals, or people who are more comfortable and more familiar with death and dying, is to help family members or care staff or whoever the person lives with to not be so afraid of the process of dying, and maybe to be more maybe to understand what it is that they do and don't have to do anything about, you know, because if you've never seen somebody die, then it can be quite frightening if you see that somebody slips into consciousness, or their breathing goes quite noisy, or, you know. So I think the work you're doing, Kathryn, and helping people understand that that is actually what comfortable normal dying looks like, is so important. I think, in my experience, what families and carers or care staff, if they live in a staffed home, need most is just the assurance that it's okay, that, you know, that all they have to do is be there, and they're doing okay. And then, yeah, I mean, people, it's wonderful people can stay at home, but it's, I mean, in my experience, where people want to be when they die is somewhere where they feel safe. And for some people, feeling safe is in hospital because they want the safety of the, you know, of having doctors and nurses around. As long as you can be with the people you love. Of course, that's been the difficulty during COVID, is that you often have to make that choice. You know, if you're in hospital, you can't be with all the people you live with at home, and vice versa.
Yeah, I think that's really important. And I think the webinar that you ran, Irene, and I've also been involved in a webinar recently run by an organisation called the Art of Dying Well, which was looking at accompaniment of people at the end of life, might be two really useful links for people who are watching now. Because in both cases, what we're doing is, again, it's the storytelling of what the ordinary process of dying looks like. And there is an ordinary process of dying, and that is a surprise to a lot of people, just like there's an ordinary process of giving birth, but also occasionally that process gets interfered with, and then we need midwives and obstetricians to help and to intervene. But usually it can happen just on its own. Dying has a sequence of events that's recognizable and is mainly about getting more sleepy and becoming gradually unconscious. And if the person were to have any symptoms during that time, they would be symptoms of the illness that they're dying from. They're not symptoms that are caused by dying. So it's really important that there are good plans in place for whatever symptoms might come up. And usually those can be planned to be given at home, provided people have the confidence to give those treatments. So when we were talking before about that storytelling in bereavement, of making sense of what has happened, the thing that's really surprised me about the book is a number of people who've written to me and said, I was with this person I loved as they were dying, and I saw them, their breathing got very fast and it got very slow and it made funny bubbling noises, and I thought that they were breathless, I thought they were drowning, I thought they were choking. It was awful. I've lived with that trauma for years and years. And then I read in your book what the usual process of the breathing changes are and the funny noises that can happen as people are dying, simply because they don't feel their throat, so they don't clear it anymore. So their phlegm bubbles and crackles a bit at the back of their throat. And that I wish somebody had told me that at the time. And I realised we really do need to help people to understand right across the nation that this is what unconsciousness as we approach death looks like. The person isn't suffering or distressed during that phase, and we can comfort each other with that information, and that can help families to be calm. It can help care home staff who feel a little bit uncertain about, is this a person who should be being moved to the hospital or not, to think about what's actually going on, and what's most important for this person is perhaps being in an environment that's familiar with people who they love, rather than being in an environment that can do lots of clever stuff that isn't particularly relevant at this stage in their illness. So it's all about telling the stories, not because they're fiction, but if we present the facts in a story form, I think we hear them and we retain them far better than, here's a list of important things to remember as somebody dying. It's gone out of your head the minute you've read it, hasn't it? Whereas if you're hearing the story of a person whose story you're interested in during their dying, you'll think, oh yeah, my dad's making that noise that I read about in that story about that French guy. This is the same thing.
And can I ask you a question, Kathryn, then? Because in the last number of years, I've been, I would say, fortunate to be around the last day or days of a number of people with learning disabilities that I've loved and been close to. And on almost all of those occasions, nobody seemed to have picked up that the person was actually dying or very close to death. And so there was a lot of, not recognizing this and maybe rushing them into hospital or whatever. And it wasn't until because I'm a palliative care nurse and I've seen many people die, I recognize those signs, right? So when I said, actually, I think they are dying, that then a doctor or somebody said, yes, that's right, right? So my question is really, how can we help people, families and people at home to really recognize, or to be helped to recognize that this is what's happening? Because quite often I see that people are panicking and want to do something because nobody has dared say, actually, they're dying. This is the point of no return. This person, what you need to do now is not, rushing about, or you need to sit with them. And all it took is for me to say, I think they're dying, let's just sit with them. And I was, and it made for, in those cases, thank you, very, a good death, because the person had people around.
Yeah, that's so important, isn't it? So one of the things that I think is interesting is that when you look at the data about deaths of people with a learning disability, we know that people who should have their normal average life expectancy for their age don't live to the age that people without learning disability live to. So something's going on there about their health care, their well-being that we need to examine. And some of the time we fear that it's actually contact with hospitals where there are judgments made about what to do for a person who has a learning disability that are different from the judgments that would be made for a person with the same condition at the same age who didn't have a learning disability. So there's a lot of learning still to happen in healthcare. But also there's the story which is very familiar to a lot of us for a person who's with or without a learning disability becomes suddenly and very seriously unwell and they get taken to hospital. And they're in the hospital and their family is told, oh, you know, he's quite sick, you know, his kidneys aren't working very well. But we've got a drip up, we're going to give him some hydration. Or she's, you know, we're quite worried about her, you know, because her oxygen levels are very low, but we've got piped oxygen now, she's got a mask on. Oh, we're quite worried about this person because their blood pressure is really low. And we're doing this and that to change their blood pressure. Now, I'm a doctor. When a doctor said that to me about one of my family, I would know what they're saying is, your relative is so sick that we think they might die. But if you're not a medical person, unless somebody says this person is so sick that they could die, you know, I'm really worried your dad might not survive the night. We're doing everything we can to return him to good health. Your beloved brother with a learning disability has had a blood clot in his leg and it's moved into his lungs and he's really struggling to breathe. And we might not be able to save his life here, but we're going to carry on trying. And now we're in this interesting place where the person might die and the person might be saved. But we don't want to discover tomorrow that they can't be saved and there were things that we could have done and said today while there was still time. So I think the first thing is that we've got to help healthcare staff to use their D words to actually make it plain to families, as you did. I think this person is dying. I think this person, maybe a D word feels too hard for you. And I've been saying to my colleagues who are having to have these conversations over and over, you know, you might actually feel that you just traumatized yourself by having to say dying, dead too many times in a day. But there are ways of saying it, aren't they? I don't think your brother can survive. I'm really concerned that they won't live till the morning. To help families to understand what's going on.
Yeah. So there are questions about the taboo of death, why it is so hard for us when we're all going to die. It's the one thing we all have in common, we're all going to die, and yet we find it so hard to use the D word. What you've been doing, both of you in your own ways, is to try to get that conversation going during this time, as always, but especially during this time, taking account of the fact that sometimes it's going to be difficult for family or friends to visit. Raising that awareness, what more could we do? How could we build on your experiences during the pandemic to try to make this more widespread? Somebody has written in the chat a very, very sad story about how his father died without them having communication from the hospital. And this is tragic. Trying to repair your own kind of, you know, understanding and, you know, having had an experience like that is hard. And, you know, I'm sure all of our hearts go out to you, but how can we make this a more ordinary topic of conversation? How can we have more Kathryns and Irenes encouraging and enabling those conversations about death and dying? You know, I was also asked back as a doctor. I decided I was far too long retired, but also I've been doing other things during the pandemic. But it did occur to me that the one thing I would have been interested in doing would have been talking to staff working in social care to try to have those kind of conversations, Kathryn. So it's fantastic to hear what you've been doing in the hospital setting. How can we make this more possible?
I wonder whether we need to change the responsibility from it being healthcare professionals will always encourage us to have these conversations to actually anybody who's mortal, which, you know, spoiler, that's all of us, really needs to step into thinking not just about dying, but living. because that's what these conversations really need to be about. What's important to you? What matters to you? So that throughout your life, the decisions that are made about you, if you're not a person who's able to make your own decisions, or the decisions that you make, or the person you've authorized to make decisions for you makes, fit always with what matters most to you. And a doctor who's never met you before can't do that, can they? So there's something about having a national drive to planning ahead, to saying about the things that are important to me, so that when we do suddenly come unstuck and there are important conversations, you're picking up, you know, if I come to the hospital and I'm your doctor, I'm picking up a conversation you've already been having with your family and friends instead of introducing it for the very first time.
Irene.
Yeah, it's interesting, and it's in fact, I've just started a new podcast series, and we did our first episode 2 weeks ago. If you go, and that's about exactly that topic, about how difficult it is to say the word death and dying, and the euphemisms we use instead. And I mean, the euphemism you've just given us, Kathryn, is a medical one, you know, or his oxygen levels are low, or, you know, all these sort of things that actually don't say what it is the person may be dying. So the podcast is is with the PCPLD network. So I think I put a link in the chat box if you're interested. It's about 20 minutes long. And we're asking 4 people with learning disabilities what it's like for them to hear somebody's passed or somebody's lost. And it's very confusing, you know, if somebody's lost, then why don't we go looking for him? Passed, you know, they said, well, they passed what, an exam or in the street or what? So if you ask people with a learning disability, what words would you use? They say, just tell me he's dead. You know, so, and I think it's remarkably difficult to say the D word, even for very experienced staff. I remember talking to one staff member, asking her, you know, do you tell people that, you know, the other resident, that somebody has died? And she said, yes, we do say he's sleeping. You know, and I think she didn't really, that was an experienced home manager, and I don't think she heard what she herself had said, that she hadn't actually used that word, and it's very, very confusing. And I think, as you say, I think we just need to be more at home with the fact that we are all going to die, and let's talk about it. And I think it's just a matter of experience. One of the most interesting comments on that podcast we did was somebody who almost sounded surprised, saying, oh, actually, saying the word dead is much easier than saying lost or passed or kicking buckets or pushing up daisies or whatever it might be. And it doesn't, and as you say, Kathryn, it's you know, if you say the word, it doesn't make it happen. You know, as somebody said, in the same way as talking about sex education doesn't make you pregnant. You know, it's just something that we all need to know about and have the vocabulary for. And that's why people with learning disabilities, I think, can really help us, because they need the simple, straightforward language that forces us, all of us, to actually use that simple language and understand it ourselves. And it is hard, because as soon as you said, my mum has died, it becomes true, more true. It's hard to say, but you need to hear yourself say it, you know, you choke up every time you say it. But it needs to be said, because you need to understand it yourself, what that means for you.
And also, we need to be thinking about dying from a very early age, don't we? We need to be encouraging parents to notice, you know, dead birds and beetles, and talk about, look, you know, this thing that looks like a bird or it looks like a beetle, but it isn't moving, and you can pick it up, you can turn it around, it doesn't do anything, it doesn't know anything, that this is a permanent state now, it's not just asleep. These children are just intrigued by death, and the really helpful time to talk to kids about stuff is before they've started to add the emotional layers that adults put onto them, isn't it? So talking about dying really early, getting death and dying into the national curriculum as part of the life cycle curriculum that already exists. We've in this country just put CPR into key stage fall curriculum, I think it is. So children are now going to be taught how to do chest compressions, but they're probably not going to be taught that the chances of that actually working, helping the person to stay alive until they get to hospital and then being able to recover in the hospital is about 1 person in 10 or less. So we've really got to get a grip on the fact that dying is everybody's business, and we help our citizens best by including these things that are everybody's business right through our curriculum.
One of the things that's really, really helpful, so talking about it, and of course there are death cafes, and but you know, ideas about death education in school, these are really important. But during the pandemic, there's been the question about, do we think about what we would like people to know about us if we were admitted? Irene, you and I worked on a resource called Jack Plans Ahead for Coronavirus. Can you explain what your thinking was in that?
Yeah, I mean, we've done a lot of work in thinking about planning ahead generally for, you know, we all need to think about death and dying and plan ahead for it. Of course, during coronavirus, we realised that it's quite possible for people to suddenly have to be rushed into hospital and having to make decisions quite quickly about what happens. And of course, if you're then in hospital by yourself without somebody who knows you, the idea behind this resource was, you know, you really want staff in the hospital to know who you are and to know what it is that is that you need to be more comfortable, or to be, so, you know, if you have a learning disability in particular, then, you know, and you can't communicate easily what it is that you need, then it's really helpful to have on a document written down, you know, these are the people that are important to me. If I have 1 person with me in hospital, I want it to be this person. I really, you know, need my red blanket with me, because otherwise I don't feel you know, comfortable. So a few essential things, and we help people to think about what those are. And I suppose in terms of planning ahead, you know, to me, I mean, you're so right, Kathryn, it's about living, isn't it? It's about thinking about, you know, if you only have, you know, a few days left to live, how do you want to live those? Who do you want to be with? You know, what would you want to happen? What if it's a week or a few months? So it's thinking about what matters to you, really, and who matters to you, and how, if you can't tell this to the nurse in the hospital because that's the only person who's around, how can you best make sure she knows that?
So the NHS also introduced grab and go guides, which you can download. And I've been encouraging, you know, friends and family to all have their own kind of 1-page profile. This is who I am. And of course, people with learning disabilities, somebody with dementia, nobody wants to be defined by their disability. I think that's really, really quite important. And so if you're not going to be able to speak up for yourself and to explain what matters to you, to have a very simple document, perhaps with a photograph of yourself doing something you enjoy, taking that along with details of, you know, who really cares about you and who you'd want to be there. But also perhaps something about the reasonable adjustments that you're entitled to as a disabled person at any stage of your life, which hospitals are required under the Mental Capacity Act to take notice of. And one of the questions that's been asked is about whether people are entitled, people with learning disabilities, for example, might be entitled to an interpreter in the same way as somebody with speaking a different language, or and of course, this is one of the reasonable adjustments that you would hope would be made for an individual. It's just been more difficult during the pandemic, and although I'm very well aware of circumstances where people have been allowed to be there, I'm also aware that hospitals have taken the view that they have the discretion as to whether to allow it or not, which has led to a lot of people being very hurt. So do you have any is there anything we can offer to people who are listening who may feel that they've been excluded and are experiencing a really difficult bereavement as a consequence?
It's been really, really hard, hasn't it? And it isn't just hospitals. There are elderly care residential facilities that, to prevent coronavirus coming into their establishments, have not allowed visitors for a very long time. And for some people, that's been during the kind of closing window of somebody's deteriorating dementia, so that they haven't seen the family often enough that they will remember who they are the next time they encounter them. So that's a double bereavement. Hospices have taken the view that they have to protect the well-being of their patients and of their staff, because if the staff get sick, they can't look after the patients, and they don't have the kind of bank staff facilities to call on that a big hospital would have. So there have been really, really heartbreaking decisions to be made, and I don't think anybody has been excluded because they weren't worthy of being allowed to visit, or that the person they love wasn't worthy of visitors. It's all been about a tightrope walk between what can we do for this individual who you love, who's the most important concern, and what our responsibility is to all of the other people who are in our care. I'm not sure that those have always been the wisest decisions. I'm sure they've been as deeply thought through as possible. But as this crisis continues, I do think we might have to examine the long-term damage that's happening and ask ourselves whether there could be a different way. But it's incredibly difficult and heartbreaking for the establishments who are excluding people too. And that's not to negate the sadness of the people who are trying to visit through windows, or can't even visit through windows because the person isn't on a ground floor. It's just horrible and difficult. Sorry, that's not a consolation.
I think, that's right, Kathryn. I think the more I think about it, the more I'm because, I also hear stories of people with, more with severe, support needs, who live in a home, and mum, who used to visit every day, now can't visit at all, and they haven't seen them for months, and they might be the only person who understands this, really deeply understands this person's needs. And the more I think of it, the more I wonder whether actually this mum has turned from a carer into a visitor. Before the pandemic, she was the carer, and that's the same for families of people with dementia. They are carers, and I wonder whether there's a way of actually including families like that, carers, on the care staff team. I appreciate the difficulty for nursing homes and care homes of having to keep all their residents safe, so they have to go through the same safety procedures as their care staff. But I do wonder whether, if mum or a husband of a wife with dementia, really I think is needed to visit every day, because they need to care for this family member. They are carers. So again, that's no consolation, because if you can't do that, it's very difficult to argue that as a family member and to say this is what I need to do. But I wonder whether that is the next reasonable adjustment that needs to be made. And a reasonable adjustment, as we know, is something that we need to change in the person's care, the way we do normally for the general population, because without it, they can't access care properly. And I would argue,
that's really helpful, and certainly I've heard those suggestions being raised in Parliament as well. So I think that there and many carers themselves saying they would like to be treated as key workers and still allowed to retain a caring role. We've been asked to address a couple of other questions, and time is beginning to run out. But so briefly, there's one issue which is about the children and young people and who are involved in family bereavements and aren't able to visit. But the other one is about the role of religion and culture. On the one hand, maybe family members and friends who don't share the same faith as the person who's dying. And on the other, the fact that within our society in the United Kingdom, we have people from cultures where talking about death and dying is very much part of their culture. So we haven't really touched on those issues at all. Would either of you like to comment? Katherine?
I'll have a little go, because one of the things that we see in palliative care at end-of-life care, of course, is families assembling, some of whom are united by a set of beliefs or a set of cultural values that actually help them to have a set of behaviours that this is what we do when somebody is dying, and they take enormous comfort from doing it well and doing it properly. And I sometimes feel that my own culture is a bit impoverished in comparison. I need to leave my screen and flick a switch because I'm about to lose electricity in my laptop. Irene, please speak.
Over to you.
Yeah, I can just carry on, but I think it's so true, Katherine. It's yeah, I think that, you know, being able to do things and to cope with death and dying in the way that your family and your culture is used to is enormously comforting. And of course, that's been again one of the really difficult things during the pandemic, is that often, you know, you can't do things in the same way. You can't have these wakes before the funeral if that's what you're used to. You can't gather the crowd. You can't. Yeah, that's heartbreaking.
I think the questioner also is asking about when there are differences of opinion and understanding within a family. And of course, our concern as the carers for an individual is that what matters most to them is the thing that we will respect. So if they are a person of faith, we will try to respect whatever the cultural tradition of faith is that they adhere to. And if that's a whole different culture for us, as it often is, we then have to ask for help and to interpret how best to provide our care so that we're respecting the cultural traditions. For example, in one of the hospices where I worked, the local Reform synagogue used to run an on-call system so that after a Jewish person had died in our care, they wouldn't be touched by somebody who wasn't the right gender and who wasn't Jewish, and they would immediately come to begin the laying out for us, which was absolutely fantastic, the way they supported us. Sometimes a person is a person who has no faith, and their family are desperately hoping that they're going to come to whatever belief it is that is important to the rest of the family before they die, and that can be really hard to watch. Staff know that they must not proselytize at a bedside. Whatever their belief is irrelevant at the bedside of another person. It's really hard watching families struggling with that.
Well, I would like to thank you both hugely for this very honest conversation. I think for me that what has come through really is the importance of respect, the importance of openness and honesty and being able to talk. The word tender is just very, very important, about having trust that everybody will do their best during this time. But I think I would also like to encourage everybody who's listening, if you haven't done a sort of one-page sheet about what you would like to happen, and that could include things about your own faith, your own, you know, what is going to really, really matter to you. And of course, if there are children in your life who really, really matter and who you want the staff who are caring for you to know about, so that they can also be thought about and included in conversations. Talking is going to help. It's going to help all of us. It's going to help all of us to manage our emotions, our feelings, our responses. It's going to help all of us to tell our stories. Thank you, both of you. Thank you to all of the audience. Thank you very much to Charmaine and Alison, who've been interpreting. Thank you to Amber and Samantha, who are in the background and who did all the organisation, and who will be able to send on any contacts, websites, book details to any of the audience who would like them, and details of the recording. It's our final panel for the festival this year, but there are a few workshops left today and tomorrow, and it is, I don't think there are very many places in the workshops, but there are still some. So if you want to engage further, please do have a look online and see what you can find. Thank you to absolutely everybody, and goodbye.
Thank you. Thank you.